My name is Victoria. I'm a sports physiotherapist and we are here to talk about ACL reconstruction. This video aims to give information for patients who are going to undertake ACL reconstruction or are considering to. I will start introducing Mr. Luke Jones, who's going to talk thoroughly about what the surgery consists of.
Hello, my name is Luke Jones. I'm an orthopaedic knee surgeon and I perform approximately 120 ACL reconstructions per year. I consult at 280 Kings Road and also at 25 Harley Street, both in central London. I'd like to thank Victoria for asking me to be part of this video. The process of ACL reconstruction actually begins in the clinic when a shared decision-making process is undertaken between the patient, the surgeon, and of course the physiotherapist, who is going to guide not only your pre-rehabilitation but also your rehabilitation after the surgery. On the day of the operation itself, you will typically come into the hospital about 1 hour before the surgery starts. You will be taken to your room on the ward, at which point the surgeon will visit you and go over the consent process again. A line will be drawn on the side of the body that the ACL reconstruction is going to take place. You will also be seen by the anaesthetist at this stage and also by the nursing team, who will make sure that you go through plenty of paperwork. You will then be walked down to the anaesthetic room by the nursing team, and on arrival in the anaesthetic room, one of the specialist anaesthetic nurses and the anaesthetist will greet you there. The anaesthetic that I would typically like my anaesthetist to perform is a general anaesthetic alongside an injection into the medial aspect of the thigh, which will help numb up some of the nerves that pass across the front of the knee and can be painful after the operation. However, the choice of anaesthetic is one that you will make with the anaesthetist. Once the anaesthetic has been performed, you will be moved onto the operating table, and at this stage an examination under anaesthetic is performed. This is very, very important because it allows us to thoroughly assess the rotational stability of the knee, which can be difficult to determine when the patient is not fully relaxed. Once the examination under anaesthetic has been performed, we will then thoroughly clean the leg. Some antibiotics will be administered, and I will also place a tourniquet at the top of the thigh, which stops blood flow into the knee and makes the surgery much easier. Once the surgical drapes have been applied, the next step is to, of course, take the graft. There are a number of choices of graft that can be taken. I would typically use either the quadriceps tendon, the patella tendon, or the hamstring tendon. Of course, in patients who are over 35 or who are having revision surgery, there is of course the option of donor grafts as well. Once the graft has been taken, this will be then stitched together to form what is going to be your new ACL, and it will typically be between 9 and 12 centimeters long and about 9 to 10 millimeters in diameter. Once this has been performed, the next stage is to thoroughly inspect the inside of the knee using keyhole surgery. 2 very small, approximately 1 centimeter incisions will be made on either side of the kneecap, and a thorough examination of the entire contents of the knee will be performed. And this includes, of course, the cartilage surface of the knee, the menisci, which, as you know, are the surgical shock, the shock absorbers inside the knee, as well as the lining of the joint. Any problems that are identified at this stage will then be rectified with stitching or resection. Once this has been performed, I will then inspect the old anterior cruciate ligament, and it will typically then be resected using a combination of surgical blades and shavers. The next step is to drill the tunnels through which the graft will be drawn into the knee. This is a very technical aspect of the operation, and I will typically spend some time ensuring that the tunnels are in a perfect position. Once the tunnels have been drilled to the right size to accommodate the graft is drawn into the knee and then fixed both on the thigh bone and on the shin bone, typically with a combination of screws and buttons. Once the graft is in the knee, a further examination under anaesthetic is performed. This is really important because it allows us to check that any rotational or anterior to posterior instability has been corrected. If there remains any rotation instability, then I will typically perform an additional procedure on the side of the leg where a small piece of tendon is taken from the front of the knee and plugged into the side of the thigh bone to act as a belt and braces to further instability. The tourniquet is then released, any residual bleeding is stopped, and the knee is then sutured. There will be absorbable sutures placed from the location of where the graft is taken, and then there may well be some further sutures in the site of the keyhole surgery itself.